We'll wait till about 12:05.
Is that everywhere?
If anyone has not grabbed the two handouts in the back of the room, if you could please grab them, we'd appreciate it. Thank you. Just give everyone a second to sit down and settle. Okay, so I think we'll get started, folks, as people are trickling in. For those of you who I don't know, I'm Dan Choi. I'm from the Division of Pediatric Hemonc here at UIC. I am just going to do a couple of quick housekeeping things, and then we'll do the formal introduction of Dr. Chitler. This talk is partially being supported by the France Foundation, which is a private foundation which works with the ACGME to assist in continuing education activities for physicians and a whole host of topics, not just pediatrics specifically. And so as part of France Foundation contributing to this Grand Rounds today, there were just a couple of bookkeeping things they asked us to do. You'll see a little informational handout here called Novel Therapies in Hemophilia. That's for you to keep just for your information. And then what you will also see is a sheet that says activity pretest. We hope you will do this. You're not going to be graded on it. This is really meant to see whether this as educational activities can really be of use to clinicians who take care of patients with hemophilia. So if you guys wouldn't mind doing the pretest during the first couple minutes there as Dr. Chitler begins her talk. There's also in the middle of this packet a evaluation. We'd really love it if everyone would fill out the evaluations, and you can just leave them all on the back table there on your way out at the end of the hour. And then there's also a post-test as well. So if you guys wouldn't mind please filling out all three sheets before you leave Grand Rounds today, we would really appreciate it. And so to introduce our speaker, I'm going to invite up our second-year Peds Hemonc fellow, Nidhi Bhatt, to introduce Dr. Chitler.
Hi,
Hi, good afternoon, everybody. We have Dr. Chitler over here. She's a Barnhart Lusher Hemostasis Research Endowed Chair and a professor of pediatrics at Wayne State University. She serves as a director of the Hemophilia Treatment Center and the Special Coagulation Lab at Children's Hospital in Michigan. Dr. Chitler is an invited member of the National Hemophilia Foundation's Medical and Scientific Advisory Council. She is also a member of the Board of Directors of the Hemophilia and Thrombosis Research Society. Dr. Chitler has multiple book chapters and multiple publications. Her research interest is in global hemostasis assays with clinical focus on bleeding and thrombosis disorder in children and special interest in women. Please help me welcome Dr. Chitler.
Thank you very much, Nidhi, for those kind words. Good afternoon, everyone. I'm Meera Chitler, and thank you for having me here. I'm really looking forward to this opportunity to get a few minutes to talk to all of you. It is a long talk, I just want to warn you, and I'll try my best to get through it as quickly as possible. I would appreciate it if you do the pretest. It's sort of like an evaluation for me. So if then at the post-test, if I do a good job, that means everybody should get 100% on the post-test. That's if you already didn't get 100% in the beginning to start with. So I know some of you will probably do that anyways. So I'd like to thank Dr. Neufeld and Dr. Kessler for giving me this opportunity. They put this deck together and have done a fabulous job of trying to incorporate all the salient features of the new innovations in hemophilia therapy that we are currently able to experience. That's a disclosure which I'll let you read later. So today what I'd like to do is to discuss some pharmacologic properties, safety and efficacy data on the new therapies for hemophilia. And specifically actually hemophilia A, because I think we have so many new things come up here. And we'll see if we can apply this patient-specific information for prophylaxis for a patient with hemophilia A. We have a couple of examples to see if we can help people make a decision as to how they would manage patients with the new therapies. So I'd like to start with history, as usual, I guess. So this is sort of a timeline of what has happened in the field of hemophilia therapy. So it was in 1803 that the hereditary manner of transmission of hemophilia was first described by Otto. So in about 40 years later, Samuel Lane actually saved the life of a 12-year-old boy with postoperative bleeding that ended up needing a blood transfusion, and he actually was able to stop the bleeding with a whole blood transfusion at that point of time. So it took about 40 years once we knew that this was an X-linked disorder to figure out that it was actually a blood issue. And then in 1893 was when the first time that they showed that the PTT was the test that was prolonged in these patients. And in 1911, they showed that if you add normal plasma, it actually corrects this prolonged clotting time that you're seeing. But it wasn't until 1923 that they actually used, or they were able to use, a plasma transfusion in patients for other problems, not necessarily for hemophilia. So it took a long time between the first description in 1803 and then in 1923 was the first time that plasma was actually thought of as a intervention for patients with hemophilia A. The differentiation between hemophilia when Biggs and all were able to show that the plasma from a hemophilia B patient actually corrected the clotting defect in a hemophilia A patient. That's when they realized that there were two different types of hemophilia that was there. And in 1964, Dr. Judith Poole was able to extract cryoprecipitate and showed that this had concentrated factor VIII in it, which was extremely useful for patients with hemophilia A. So this discovery really changed the whole landscape of how hemophilia was managed and being treated up to that point of time. Until then, patients had to go to the hospital and get hours of plasma infusion in order to be able to correct their problems or take care of bleeding episodes. So when cryoprecipitate was discovered in 1964, there was more than 8 units of factor VIII per ml, which means with a small volume transfusion, patients were able to be treated very quickly, which means that they could come to the outpatient clinic and get treated. And after some time, they could actually get this at home. Blood banks were able to cater to patients. They were able to distribute cryoprecipitate in the blood bank and take care of these patients. So this really changed how hemophilia was managed very effectively. In addition to that, the amount of factor VIII in the cryoprecipitate was significantly larger compared to the FFP. So patients were actually corrected much more rapidly to a much better level, which meant their bleeding episodes were controlled much more effectively. Unfortunately, all of this came at a price. Hepatitis B was first described in the 1960s, and the first antihemophilic factor was actually manufactured in the early 70s, and that was Hemophil. In the late 1970s, about 75 to 95% of patients with hemophilia were already HBV positive, and 70% of them were known to have what was called then non-A, non-B hepatitis, which is actually now hepatitis C. HIV wasn't identified till the early 80s, but unfortunately by the mid-80s we knew that 80% of our patients with hemophilia were HIV positive. This actually led to a lot of innovation in how our plasma-derived products were then supplied to our patients. So they came up with interventions that could decrease the viral transmission. So heat treatment and viral inactivation procedures really became something that people were interested in and started looking at to try to make these products safer. But unfortunately, in the early 90s, up to 75% of our patients were HCV positive. This also led to the evolution of recombinant products. Because plasma-derived products had all this risk for viral transmission, people started looking at how they could generate recombinant products. And early recombinant products came into play somewhere in the late 80s. So let's look at what patient population we're looking at. First of all, it's a rare bleeding disorder. It's still very rare, even though at these big centers, we see so many patients that we forget that these are rare bleeding disorders. So factor VIII deficiency occurs in about 1 in 5,000 males. There's about 20,000 US patients in the United States today. Factor IX deficiency is much less frequent and about 5-fold less. So most of our treatment centers have very few patients with hemophilia B and probably 2 or 3 times the amount of hemophilia A patients. Clinically, however, both of these are very similar in that patients with severe disease have the same kind of bleeding manifestations. They all suffer from joint bleeds, they all have muscle bleeding, and those are characteristics of patients with any factor deficiency and typically 8 and 9 deficiency. We usually classify the bleeding episodes in these patients as either major or minor. Major refers to either a joint bleed or intracranial hemorrhage or a psoas bleed, something that's going to cause significant problems. Minor bleeding classically is either mucocutaneous bleeding or small soft tissue hemorrhages or hematomas that we see. So the catastrophic HIV and hepatitis C before the mid-80s, sort of the focus initially was just trying to take care of these patients who had all these viral infections. The focus on taking care of the bleeding was actually sort of secondary, became secondary for a short period of time. And so bleeding now has come back to become a major focus for us because now viral transmission is not something that we're as concerned about. We want to make sure that our patients don't have any of these major bleeding manifestations that we talked about. So management of joint bleeding, patients being on prophylaxis has become such a serious emphasis that we don't see many of these major bleeding problems. Many of our patients have never experienced a really bad bleed. They don't know what it means like to have a terrible bleed that would require them to be inpatient most of the time. So inhibitors actually are much more difficult problem to manage nowadays than bleeding complications. And unfortunately, it occurs in about 1/3 of patients with hemophilia A, especially those with severe hemophilia A. And that's the most important complications other than joint bleeding that we see in patients to this day because viral transmission is not the same anymore. So treatment mainly consists of putting patients on prophylaxis or preventing bleeding is what our emphasis is right now. Of course, economics we cannot forget because we know that prophylaxis is actually a possibility only in the developing world. Developed world. In most of the developing world, patients have hardly any factor that they have access to. And so prophylaxis is not even an option. Most of these patients cannot even get factor to treat a bleeding episode, forget about treating prophylactically. So this is something that we have to think about, because we want patients all over the world to be able to have access to these kinds of factor products, or something to be able to manage their bleeding manifestations. And I think some of these novel products that I'm going to talk about today really may change the whole hemophilia landscape in the developing countries, because they don't have access to factor, and to be able to treat once a week or once a month would make something actually be accessible to these patients. And so that's but cost is always a major issue, and that's something hopefully that industry will think about and try to make it available for everyone. So now we have all these emerging therapies, and this is truly an exciting time to be in hemophilia, because for a long time it was just a matter of we had all these different factor products, and you would give a patient this product versus that product. It was pretty much the same dose. You would sort of try to titrate it to try to prevent any breakthrough bleeding, or perhaps try to titrate it to the activity level of our patients. But now we have different ways of managing, not just replacing the factor. There's so many new innovative therapies that have come into play that I think it has truly challenged how we can manage our patients with hemophilia. So severity of hemophilia, like I said before, severe, mild, moderate. I know most of the people in this room know everything about this. For those who don't, severe refers to patients whose factor level is less than 1%. These are the patients that tend to have spontaneous bleeding. I don't know, Dr. Warrior always taught me that there's never a spontaneous bleed. There is some minor trauma that you forgot. So there is really no spontaneous bleeding. Some minor thing happened. Unfortunately, in these patients, normal activity can be the trauma. Climbing upstairs can be trauma to the joint. Jumping off a table can be trauma to the joint. These may not necessarily be considered by the patient as a traumatic event, but these can be trauma to the joints that are involved, and therefore that can result in bleeding. Intracranial hemorrhage is also a major bleeding complication that is almost essentially seen in severe hemophilia patients, may be seen in moderates, but very rarely in mild, unless it's associated with severe trauma. Inhibitors, again, is a complication that is seen mostly in severe hemophilia, but can occur in those with moderate and mild as well. Severe hemophilia mostly occurs from large deletions or inversion type mutations, where a large portion of the gene is missing, and therefore they're not able to generate any factor VIII. Moderate hemophilia, on the other hand, has factor VIII levels between 2 and 5%. They tend not to have these spontaneous episodes, as we call them. They are able to tolerate normal daily activities without much of a problem. But when exposed to trauma, they can definitely have bleeding complications. Therefore, they also don't have as much arthropathy as we see in severe hemophilia patients. Mild hemophilia, on the other hand, has levels between 5 and 40. They don't necessarily bleed at all unless you do something to them. So unless they undergo surgery, have experienced some kind of major trauma, most of these patients go undiagnosed. And inhibitors, although uncommon, are not impossible in this population. So we have to remember that. And even though these inhibitors are mostly seen in childhood population, they can occur as the patient gets older as well. So differences between adults and children. Children are not little adults, and they're not just little people either. And so there are different challenges that we face when we take care of children versus the challenges that you face when you're taking care of adults. Like I just said, the risk of inhibitors is probably the highest in the pediatric population, because those tend to occur mostly within the first 30 to 50 doses of factor infusion that you give, which is most likely to occur in the childhood period, other than when you're a mild hemophilia. And so this is the highest risk period, but that doesn't mean that adults cannot get it. Children also, unfortunately, have the shortest half-lives. They are the ones that are most active. They are the ones that want to participate in all the sports. They are the ones that have the most difficulty giving themselves prophylaxis because their veins are little. And unfortunately, they are also the ones that have the shortest half-lives. Children under 10 years of age have the shortest half-life compared to any other population. And so it's important to know what the half-life of our children is when we try to dose our factor or try to manage these patients. Adults, on the other hand, still those who lived to become adults still are challenged with facing the side effects or the complications of all the viral transmission that they have undergone. Hepatitis C was a major killer. The emphasis on was. Now that we have such good therapeutic options for patients with hepatitis C, hopefully, I am a pediatrician. I don't know if I'm saying something wrong, so please correct me if I am. But I think these medications are amazing. At least what I've heard in the meetings are like you get 99% cure, so it looks like there's really been a change in that. So in adults, of course, they've never given themselves prophylaxis. That's just not been something that they did before. They didn't have that opportunity to do that before. To trying to convince somebody who's never done it for 45 years to start prophylaxis for the first time can definitely be challenging, and I can imagine that. So, and also, what product would you choose? Would you choose plasma? Would you choose something else? They're used to one thing. They don't want to move to another thing. I think we're all fixed as adults, and we're not very flexible people. And so that makes management of these patients equally difficult, I think. So this is just an example of some of the products that we have for factor VIII, and it gives me the opportunity to talk about all the different nuances that we see in these products. So you can broadly divide the products into either plasma-derived or recombinant products. And plasma-derived, because we're not touching it, we're just separating the factor of interest there. It's usually a full-length factor VIII molecule that you're infusing into the patient. And of course, there's nothing, different. We have a few options nowadays, not very many. So the recombinant products, on the other hand, because they are sort of artificially manufactured, depending on the cell of origin. The most common ones are the baby hamster kidney or the Chinese hamster ovary cell that is used to generate the factor. So the initial products that were first introduced were full-length factor VIII products. And these were the first generation. When we say first generation, what we're referring to is the fact that there was some human protein involved in the manufacturing process, and the final product also contained some human protein. And that some human protein refers to albumin, usually, for the most part. And the second generation means that the albumin was involved in the manufacturing process, but it is not present in the final formulation that is dispensed to the patient. These also tend to be full-length products. The third generation, on the other hand, here we have they have created these products where albumin is not involved in the manufacturing process and also not involved in the final is not present in the final formulation that is dispensed to the patient. All of this is in an effort to take away any possible viral transmission that could potentially occur. That's the reason for all of these products becoming what they are. So, and because these are generated in the laboratory, we have the option of trying to see if we can make things faster. And one of those options was to delete the B domain, because we thought that since it's not necessary for the function of factor VIII, we could take it out and maybe hopefully make it faster for the factor VIII to be produced by these cells. So that was the objective of taking away the B domain. And it has been found to be equally effective, although there are some questions about what this might do to immunogenicity. So if you talk to anybody, there are people who love plasma-derived and there are people who love recombinant, and they all will tell you very vehemently why they believe that that's the best thing that you should give their patients. So I think these are some pros and cons for each of those products. So recombinant products obviously came into being because of the risk of viral transmission. And so there is very minimal, if any, chance of transmission of any kind of pathogen when you use a recombinant product. And at our center, we still emphasize on using recombinant products. We haven't switched. We only use plasma-derived if the patient fails a recombinant product. And so there are several pediatric centers that do recommend that we should still consider recombinant products for our patients. This might change when we talk about some studies that have recently come out. There's also the potential that you can make more when you need it. It's hard to do that with a plasma-derived product. So that's an advantage for the recombinant product. It also allows you to make some modifications to that factor, maybe improve the efficacy, maybe improve the half-life, maybe do something. So that can't be done with a plasma-derived product. So the plasma-derived, obviously, even though we talked so badly about it all this time, there has not been a single viral transmission reported since the early 90s. So it has been extremely safe. Albumin has been around for even longer than that and has never been associated with any viral transmission at all. So it is still extremely safe. The products that are currently available are very, very good. They are less expensive, much less expensive than the recombinant products. And there is thought to say that maybe there will be less inhibitors with this as compared to the recombinant products. We'll talk again about that. So this is some recent other recombinant factor products. I'm not sure why it wasn't added to the previous table. So the Novo 8 is a truncated B domain. Again, it's a third generation product. They claim that the incidence of inhibitors is lower than the other products. I think time will tell whether that's really true. Covaltry is a full-length recombinant factor 8, and again, it's also a third generation factor product. So I think this was a seminal study in the whole practice of hemophilia. We've always known that joint bleeding is bad in patients with hemophilia. It was just a matter of trying to understand how bad is this and how well does prophylaxis work to prevent this. So Dr. Manko Johnson did this amazing study a few years ago, the joint outcome study, where she took 65 boys with severe hemophilia A and randomized them to get either prophylactic therapy or episodic recombinant factor 8. And they followed these patients using MRIs. They got a pre-initiation of study MRI, and then they followed them over time. And what they found was that patients with prophylaxis, who got prophylaxis, like they said, had 93% of those patients had a normal joint structure, compared to only 55% of patients who were on episodic therapy. I think that is compelling information for us to say we have to put our patients on prophylaxis. I think we've always known this, we just didn't know what the numbers were, and this study helped to emphasize that. And so the number of joint bleeds per year, obviously episodic was 4.4 per year compared to 0.2 in those who were on prophylaxis. There was an 84% relative risk reduction. So I think this was a remarkable study in that it could be done, and they were able to demonstrate that. It's really hard to do studies in hemophilia, and she proved that she could do that. So like I said before, activity obviously increases the risk of bleeding. And I think we're always looking for numbers. We want to do evidence-based medicine. Evidence, unfortunately, means I need numbers. I need to know exactly how this works. And so this was a study in Australia that they conducted between 2008 and 2010. And they studied about 104 patients, teenage patients with hemophilia, moderate and severe hemophilia A. And they classified activities as I think category 1, 2, and 3. Category 1 was activities like swimming, where there was no expected collision that was expected at all when you did this activity. Category 2 was that there was a significant chance of collisions, but not as bad as something that was involved in activity 3. So playing basketball was an example of a category 2 activity, and wrestling was an example of a category 3 activity. What was interesting to me in this study was that they found if a patient has about 5 bleeds a year that are trauma related to the activity of this patient, what they found was that only one of those bleeds could actually be related directly to the activity that that patient was doing. 4 other bleeds were not necessarily always related to that formal activity. There were other things that the patient did. So the question is, how much restriction do our patients need? One. Second thing that they showed was that for every 1% increase in factor 8 activity, there was a 2% decrease in chance of having a bleed. So that I think was very interesting. So even though they were doing these activities, there was a reduction in the amount of bleeding episodes that they saw. So that was very interesting to me. So I think this is very important now because we want our patients to lead normal lives. All our patients want to participate in sports. They want to be part of teams in their school. They want to be able to do all these things that keep them normal. And if that's the case, we need to be able to quantify what this means in terms of risk. If you're going to play football, what does this mean in terms of risk for you having this disease? And these types of studies are what help explain that to us. And I think this graph is very, very important for us to understand at this time. I think we've always needed to know this, but not as much as we needed to now, especially with all these new different kind of products that are coming in, and the fact that we can actually give our patients the opportunity to participate in all these activities, which means I need to know exactly what these levels need to be for you to be able to participate in these activities. So when you look at a PK curve, we know that if you are in the peak, so this portion in the green is actually what changes you to normal hemostasis, which means that activity-related bleeds can actually be prevented if you are in this green section. So when you're treating, if you're in this green section, you can go play soccer. I still won't say football, but you can go play soccer. So, okay? But And so the area under the curve, all this underneath here, that can help prevent subclinical bleeding. That's not as important for me to know this to be able to have you go play soccer, okay? And the trough is really what is necessary to prevent spontaneous bleeding, okay? So this, I want to keep this higher so that you don't get a spontaneous bleed. So if you're not doing anything, I still need this to be higher. Whereas if you're playing an activity, I need you to be here. So I think this understanding this graph becomes very critical at this point of time for us. It's also important in the pediatric population because each child is very different. The half-life in one child is not the same as the half-life in another child. Every child is very, very different. So you need to understand each patient separately for themselves to be able to do that. How do we do this? Do a PK study. That's the most challenging part of everything that we do here. The ISTH has recommended 11 time points to do a PK study. It's impossible to bring anybody in to get 11 time points for anything. And so now I think we have understood enough, and there have been enough computerized modeling systems that you can do where you can actually get 2 time points and still show that you can predict the half-life. So I think we have an opportunity now to really do a PK on our patients because we can do it with 2 time points. We have no excuses now to say that I can't do a PK. So this is a reason why we can do it now. Okay, so it is critical. I need to know what your peak levels are. I need to know what your area under the curve is, because this is information that can help me tailor your treatment to be able to lead the lifestyle that you want to lead. And so that's important for the patient to understand that that's what we're trying to do. And I think showing that curve to the patient actually helps them understand what we're trying to say. When we say treat in the morning or treat at night or treat before you go to play something, I think showing them the graph gives them a picture of what we're trying to achieve, and that's really, really important. So now we have new therapies. That makes it even more important for me to know what the PK is, because these extended half-life products give us the opportunity to treat less often. But how less often? Each child is different, so I have to know how less often I can treat in one child versus the other child. So if you're a 3-year-old, I'm probably not going to be treating that less often. But if you're a 13-year-old or a 23-year-old, you're probably going to be treating much less often with these extended half-life products. So I need to know what the half-life is in each of these generations to be able to predict how I need to manage this patient. So let's talk a little bit about what the technology is behind all these extended half-life products. So I showed you 2 products. One was an FC fusion, one was a pegylated product. So how does this help? So the proteins in the body are normally recycled, the ones that we want, like albumin, okay? They are normally recycled in the body so that we can make use of them for longer periods of time. So they tend to have long half-lives because they actually have the FC region fused to them. So these proteins, when they're endositized by the endothelium, they go into the lysosome, but they're recycled. They don't get destroyed in the lysosome. Anything that has an FC portion attached to it gets recycled and comes back out. So that's the way they targeted this. So the neonatal FC receptor inside that lysosome is able to recognize this constant region of the IgG and then spits out this protein back again into circulation and without destroying it. So that extends the half-life of several proteins that are important to the functioning of the cell. And so they targeted this technology and attached the FC region to a factor VIII molecule so that the factor VIII, when it gets endositized, can come back out and so maybe extend the half-life. Okay, so that's a cool idea, but unfortunately with factor VIII, what we forget is that factor VIII does not circulate in isolation in the system. It circulates in conjunction with von Willebrand factor. So von Willebrand factor plays a major role in the half-life of the factor VIII. So unfortunately, unless we change the half-life of the von Willebrand factor, we are not able to get a significant extension of the factor VIII half-life itself. Okay, so that limits how much we can do with factor VIII. This has been very successful on the factor IX end. Patients with factor IX or hemophilia B are able to treat twice a month with the FC fusion products. The older patients are. So unfortunately, we can't say the same for the factor VIII molecule, potentially because of the fact that it's so dependent on von Willebrand factor. However, the studies that they did initially on these kids did show a significant increase in the half-life, and they were able to decrease some infusions during the week. So depending on the dose that they used, they were, so this was a comparison between individualized prophylaxis, that means they actually did a PK, determined how often the patients need to treat, and it was either 3 days or 5 days. And so they got anywhere from 25 to 65 units per kilo, and they showed a decrease in the ABR. Those who were on episodic had 33.6 was their annualized bleeding rate, whereas it was 1.6 in the group that got individualized prophylaxis. Even if you didn't individualize it to the PK, if you just put somebody on a standard dose of 65, I want you to pay attention, it is 65 units per kilo. We don't usually use 65 units per kilo when we use a regular recombinant product. So this is higher than what we would target for somebody who's using just on a regular recombinant product. But they still, at this dose, were able to do once a week, and they still had a significant decrease in the annualized bleeding rate. Okay, so it did make a difference. And if you imagine there's a little baby who gets treated 3 times a week, if you tell this mom you can treat this baby once a week instead of 3 times a week, I think that mom would do anything to poke that baby twice less a week. It makes a huge difference in little kids to be able to do that. Okay, so there were no inhibitors also in the kid study that they did. So they showed they had 71 previously treated patients less than 12 years of age. They all started on the different dosing regimens, and they really didn't have any development of inhibitory antibodies. And the ABR was significantly low in these patients as well. Okay, so this was the pegylated product, had similar results. Episodic 41.5, whereas those who got treated with the individualized prophylaxis came down to 1.9. So there was significant decrease in the number of bleeding episodes that you got, and they also did not develop any inhibitory antibodies, which was beneficial for this. So this is the other product called Newick. Okay, so this is what we call a 4th generation factor product. I talked about 3 generations so far, and these 3 generations were manufactured either in this CHO cell or the BHK cell. So now what they're doing is manufacturing them in a human cell, okay, in a HEK. And so that has been classified by the MASAC as the 4th generation of factor product. And so this introduces human processing and modification. And the thought process is maybe this somehow might decrease the development of inhibitors in these patients. So they have tried this on 135 adult and pediatric patients so far. They have actually shown a half-life in this study of 17 hours, and there were no evidence of inhibitors in 135 PDPs so far. So this is promising if that half-life can really be 17 hours. So this is F-Styla, which is again a single chain factor 8. What they did was they covalently bound the 2 chains and the light and heavy chains, and this increased the binding affinity to von Willebrand factor about 3 times. Unfortunately, the half-life didn't change that much. It was only about 13 hours, which is still better than 8. In some of our patients, the half-lives are 6 to 8 hours. So if I can get 13 hours for that patient, it might make a difference in how much they bleed. So it's still better, but still not as much as we would have liked. Okay, and so even for these patients, some of them were still, 6% of these patients needed every other day treatment. 54% of them were on 3 times a week, and 32% of them were able to come down to 2 times a week. So again, even if I cut down from 3 times a week to 2 times a week, it's still 1 less poke for that child for that week. And so that makes a difference for our pediatric patients. So this is what I was talking about regarding the association of von Willebrand factor and factor 8. And so what they did a pilot study in 12 young adult patients with severe hemophilia A, and they looked to see if exercise resulted in a shorter half-life of the factor 8, okay, or if exercise resulted in a longer half-life of factor 8, because when you exercise, it increases stress, which means your von Willebrand factor goes up. Does that somehow alter the half-life of the factor 8 in the patient? So the von Willebrand antigen actually rose about 40 to 50% for about 6 to 8 hours. But unfortunately, that didn't change anything for the half-life of the factor 8 for these patients, okay? But there were no bleeds during this study. So that was interesting to note. So in summary, I think what we've achieved so far with the extended half-life products is that we've got a modest prolongation of factor 8 levels, okay? So the half-life is about 1.5 times. So that means a few less infusions that were needed. That also means fewer ports that were placed, right? And less ER visits for potentially, fewer interruptions for the family, fewer interruptions of school for the child, and improved quality of life. If I have to poke less, it makes the mother feel better, it makes the child feel better. It just really improves the quality of life. And also, of course, if you're bleeding less, that's really great. So let's talk about a case and see how we would manage this. So this is a physically active 25-year-old, not necessarily pediatric, but young adult. So bleeding history is that he was started on prophylaxis in 1996 and with twice weekly recombinant factor 8. He rarely bleeds on this regimen of 3 times a week, and he gets 25 units per kg. And most of the time when he bleeds now, it's only traumatic, when he twists his ankle or something like that. And his right ankle has been the target joint, but it doesn't cause him any problems. He does swim, and he's an active cyclist. His half-life when they did it was about 14 hours. So now that you have all these other choices of the extended half-life product, what would you like to do? Would you like to switch to a longer-acting product? And if you switch him to a longer-acting product, would you change the frequency of infusion? Do we have time? I think we should be okay, maybe. So I'd like to see what ideas you guys have. Sorry?
She's keeping everything the
I'm
same.
keeping everything the same,
Right,
not
don't
changing
fix it.
anything, working for him. What's the cost difference?
Oh, it's significant. It is significant.
Shorter number.
I think it is at least 2 times, if not more,
For the new one.
for the new ones. So, yes, I think one of the options is to do nothing. If it is a cheaper option, and especially because he's a young adult, he may not have the same options. You know, in about 5 states in the United States, including the state of Michigan, we have children's special health care. And children's special health care covers all hemophilia-related treatment for the entire lifespan of the patient. I don't know if you guys have it here. Do you? No, you don't. So we are a little spoiled in Michigan in that we don't necessarily always think about the cost of care when we're thinking about what product to use in our patients. But I understand that that's not the right way to approach things, and we do talk about it now, but it doesn't sometimes prevent people from doing things. You know, patients will walk in and say, I want that new thing. You know, even though they're going to be using it for the exact same frequency and probably doing a higher dose in order to be able to participate in whatever they want to participate in. But because they're not paying anything for it, they think that it's okay to do that. I don't think it's right, but I don't know that I can tell the patient you can't have it. So when they have the option of getting it, I can't deny them that opportunity. But at the same time, it's unfair that only some people can get it and others can't. But it's not that patient's fault that they can get it and somebody else can't. So it's sort of I cannot justify anything anyways. So if they want it, I give it to them. So, but I can understand that in other states where that's not an option, you have to think about cost, because patients are constantly switching jobs in order to be able to get over that cap that they have for their factor product. And so if that's the case, that's a conversation that needs to be had with this 25-year-old to say, you do have this option of going to this extended half-life. We will do a PK, and if your half-life on the new product is 18 hours instead of 14 hours, it doesn't really change the frequency with which you're going to infuse, potentially. But if your half-life is 24 hours instead of 14 hours, that could potentially change what we do. We may be able to give you less infusions, which overall might not increase the cost as much if that were to happen significantly. So that's something we have to keep in mind. So obviously this patient is doing really well. So doing nothing would be a completely, perfectly good option for this patient. Okay, so now you have Jonathan's older sister has a 5-year-old child, and she switched who switched at the age of 4 from a recombinant to an extended half-life product. And so the bleeding events have significantly reduced since he's done that. But his half-life was 7 hours for a recombinant factor 8 and 10 hours for the extended half-life. And this is not even false. This is really what you see in these patients. So, and the lab testing actually shows that his factor levels are lower in the last 2 visits. So, is something wrong? Is he not treating appropriately? What should we be thinking of? This question is not for Mindy or Lisa. No? Yes? Is something wrong? Yes. That's the first thought that should come to our mind. Is he getting an inhibitor? He's the right age. He's 5 years old. I know he switched. Switching is not been associated with the occurrence of inhibitors. I think they just put this in there just to misguide us. But that's not the reason for the inhibitor. Unfortunately, I think he's just in that age group where you can develop inhibitors, and he unfortunately might have developed an inhibitor. And that's something to keep in mind when we're taking care of these patients. Even though we understand a lot more about inhibitors today than we did a few years ago, there's a lot more to understand. We can't tell why some patients get inhibitors and why others don't. We actually have sibling pairs where one sibling has an inhibitor and the other one doesn't. And they're the same gene pool, they have the same mutation. So what made one person get the inhibitor and not the other child? It's very hard. I think there's so much basic science that needs to be learned in this area. More potential for research, more things for new people to do. So there are some patient-related factors that we know of that are associated with inhibitor development. We know that patients who are severe or moderately severe tend to have a higher incidence of inhibitors. The larger your mutation, the more likely you're going to get inhibitors, because less likely that you are making any factor VIII, which means that when you infuse factor VIII, your immune system is exposed to a foreign protein, which makes it want to make an inhibitor. Unfortunately, if there's a family history of inhibitors, there's something in the gene pool that makes you want to make inhibitors, so that's higher. If you're African American, there's a much higher incidence of developing an inhibitor. There's a very interesting study that was done about 3 years ago where they looked at recombinant factor products. And what they found was that these genes that are used in making recombinant factor product all come from Caucasian genes. There are no African American genes used. So the question they were asking was, does that have anything to do with the fact that the African American population has a higher incidence of inhibitors? I don't think they were able to conclusively say that, but they did see a significant difference. And so one of the thoughts is that what is potentially causing an increase in inhibitor incidence in the African American population? But we know that the immune response genes definitely play a role. I don't think we have this defined very well yet, but there's lots of groups that are studying these to see if polymorphisms in these genes could result in a higher incidence of inhibitors. And if it did, I'm not sure what we could do to actually change that. We would just be able to identify the patients who were at higher risk, and maybe we could change it, maybe. So treatment-related factors would be number of exposure days. Like I said before, the highest incidence is in the first 30 to 50 doses of factor that you administer. So those are the times that you have to really closely monitor the occurrence of inhibitors. But after that, it's never zero, but it significantly decreases for the lifespan of the patient. The intensity of exposure. We do know that if you're giving high doses of factor for prolonged periods of time very close together, those patients are more likely to develop inhibitors. Babies that had intracranial hemorrhages that were treated with continuous factor infusions or aggressively with factor VIII replacement because of the severe hemorrhage that they had a much higher incidence of inhibitor formation compared to other children who didn't have that bleed. So it may be a combination of things here. You have an inflammatory response in response to the bleed that you had. So the combination of that inflammatory response plus the fact that you are giving really high doses of factor at that time when your immune system is all revved up might potentially be the reason for why you develop inhibitors at that time. Could it be plasma-derived versus recombinant? So that's the question why I said maybe we can do something. Maybe if we can identify the patients who are at much higher risk, the ones who have some kind of immune response gene polymorphism that we have identified as associated with inhibitor formation. If they are African American, they have a strong family history. And they have intron 22 inversion, or they have a large gene deletion. Maybe these patients may benefit from trying a plasma-derived product. I don't know that. But that would be a study that would need to be done for us to know, and maybe potentially something to look at in the future. So age at first exposure. This is questionable. There was a very nice study that Dr. Rivard did in Canada. The thought was that in the first year, your immune system is still learning how to respond to all the stimuli that you're providing. And if you're providing a stimulus that is pro-inflammatory or bad at that point of time, maybe you are more likely to develop an inhibitor. So if we do not treat this patient with any factor VIII at all for the first year of life and allow the immune system to completely develop itself before you expose them, would that be beneficial? So what he did was a study where he did not give the newborn babies any factor 8 for the first year. They were all treated with Novo 7 or recombinant activated factor 7. And then subsequently only they were given factor 8 for any of the bleeding episodes. But unfortunately, that study did not show any difference in inhibitor occurrence between the two populations. Then they reversed it. They thought maybe when your immune system is learning how to do things, if you expose it to factor 8, maybe then it'll get used to the factor 8 and not be as likely to make inhibitors at that point of time. So they did it. They started with giving weekly prophylaxis in newborn babies right from the beginning to see if that helped decrease the incidence of inhibitors. Unfortunately, that didn't work either. So I think there's a lot more to just giving the factor or not giving the factor that makes you develop an inhibitor. So prophylaxis, I think, makes a difference. If you give prophylaxis regularly, you're less likely to have that bad bleeding episode that will result in a bad inflammatory response to which you are going to get lots of factor. So I think it definitely makes a difference to put patients on prophylaxis and try to prevent that bad bleeding episode. So this was the CPID study that just came out and really made everybody stand up on their toes and look as to what we're doing. So Dr. Pevandi presented this at ASH a couple years ago. What they did was they looked at inhibitor occurrence in patients who got plasma-derived versus recombinant factor product. They picked patients who were less than 6 years old, whose activity was less than 1%, and they had not really been treated with factor 8 before. And they had not really had significant exposure to any blood components, less than 5 times. And they randomized these patients to either get plasma-derived or recombinant. And they actually picked only 2 recombinant products that they were allowed to get. They did also try to match them for the gene mutation on both arms. So they really tried their best to do a really well-designed study, but it's really hard to do hemophilia studies. And they showed that the incidence of inhibitors on the recombinant side was 44% compared to 27% in patients who got plasma-derived product. It really, really made everybody look up with wide open eyes at the results that they got. I'm not sure that we can take this and say that everybody needs to move to plasma-derived product. I don't think so. I think there's more to it than just giving plasma-derived or recombinant product. I think there's so many other factors that we just talked about that putting all of these together would be very important. Also, majority of the patient population for this study was from Asia, either Egypt or Asia. Those were the two continents that provided most of the patients. And I'm not exactly sure that we can say that it's the same as the patient population in the United States. The gene pool is not the same exactly. Even though the mutation might be the same, the rest of the immunomodulatory genes may not exactly be the same. So there are a few differences. They did a really nice, well-conducted study, but they couldn't enroll enough patients from the developing countries in order to be able to say if that was something that could have played a role in this process. So how would you treat Jonathan's 5-year-old nephew? Ideas? We said he might have an inhibitor. I'm sorry?
5/7.
Okay, 5/7, that sounds good, right? So that's probably what I would do too. First of all, you would start him on 5/7 and then do what? And then do ITI. I would definitely do ITI. He's only 5 years old. He needs a chance to get rid of this inhibitor. I don't think there's any patient that should not get a chance at ITI. Immune tolerance therapy is what we call ITI. So everybody should get a chance to try to get rid of this inhibitor, because the best thing to treat a patient with hemophilia A with is factor 8. There's no other product that comes close to being as effective as factor 8 would be for these patients. So our objective should be to try to make sure that the patient can get factor 8 again and not have to go to something else. Okay. So the options would be return to recombinant, maintain him on extended half-life, consider a different half-life, or do a PK study on plasma-derived product. I think we should first look for an inhibitor. If the inhibitor is negative, then you can think about all of these options. Okay, I don't think I would change his product. He's on an extended half-life, he can stay on the extended half-life. I wouldn't go back to a recombinant product. Even if it was a low titer inhibitor, I don't know that I would change that. If the inhibitor goes away with waiting for some time, I would probably keep him on the same factor and watch him to see how he does. What do you think, Mindy?
He wasn't doing terrible on me.
Yeah, it seems like he was doing well. And I don't know that this inhibitor, would not have happened if he was stayed on the regular recombinant product. He might as well have developed an inhibitor on that. So I don't think that would be any reason to do that. Would I switch him to a plasma-derived factor VIII right now? I wouldn't. I wouldn't switch him at this point of time to a plasma-derived factor VIII. If he failed ITI or if he did something, if the inhibitor came back, then I might consider it. But I would look into all of the other things before I say that he should do that. If he has a 25-year-old uncle without an inhibitor, I think he doesn't probably have the family history. So I don't think he would be truly a candidate for a plasma-derived factor at this point of time. So what are the other things that we can think of? So these are the two new products, pegylated products that are waiting to come. I think the BA94 they've applied for FDA approval right now or very soon, and they should be coming out very soon. The NHGP also should be applying for FDA approval very soon. I think they're closing the study right now. But again, the half-life extensions have been about 1.5 times, so not as impressive as the factor IX products. These, I think, are truly innovations in therapy for hemophilia that we're seeing now. So there are very new approaches. So we can look at replacing the factor VIII, or we can look at trying to look at some completely different pathway, or look at a different way to replace the factor VIII. So the ACE910 is a bispecific antibody. It's called emicizumab, and tissue factor pathway inhibitor is looking at inhibiting the tissue factor inhibitor pathway. Antithrombin, of course, if you decrease that would be another way. So it's all a matter of balancing. I thought there was another slide in between there. Sorry about that. It's all a matter of balancing the process of either increasing the procoagulants or decreasing the anticoagulants. So you can look at two pathways. You can maintain the balance either by just replacing factor VIII and making it balance out with the anticoagulants, or you can decrease the anticoagulants so that they match the amount of procoagulant protein that you have. So it's all a balance that we can achieve. And of course, gene therapy is coming strong now. They have modified their vectors, they've made them much better, so that would be something. Genotyping, I'm sure your center is big on the My Life Our Future, but that's something I think we are so far behind Europeans in this respect. Nobody in Europe gets a diagnosis of hemophilia A without a genetic test to prove that. And I think we have the reverse to say here. We probably have a handful of patients for whom we have a genotype on. Most of them are not genotyped. So we should not stay far behind there. So this is how the emicizumab works, or the ACE910 works. So 8, essentially, the way it works is to connect 10 to 9A. And so that it forms the intrinsic pathway, complex. And so instead of 8 being the molecule that connects the 10 to the 9, if we introduce some other molecule that can induce this connection, would that be enough to generate thrombin? And they did that. They created a bispecific antibody with affinity to both 10 and 9. And so that when you infuse this, it's able to make that connection and generate thrombin. I think this is fascinating. This person was brilliant, whoever came up with this idea. So this is a fascinating idea. So the initial pilot study looked at 18 Japanese patients with severe hemophilia A. There was 6 per dose cohort group of 0.3, 1, and 3. And they had weekly subQ dosing for 12 weeks. And they looked at dose-dependent PK. The PGT remained short, actually short for several months, even after they went off this drug. So it has prolonged action. They were able to use factor 11A triggered thrombin generation. It's one of those things that's so different in the way it acts that you can't use the routine traditional ways of monitoring to be able to monitor this. The PTT is normal forever and is normal for so long, and the correction of PTT doesn't correlate with the degree of correction of the problem. So there's no way you can use a PTT to see how effective this product is being. Are you being too effective or less effective? There's no way to do that. And unfortunately, even the regular thrombin generation test is not able to look at that. They had to find a different activator, 11A trigger, in order to be able to see that thrombin generation correlating with the amount of dose that they gave. They said no serious, excuse me, no serious adverse events. I do want to scratch that out. Okay, so we have had 3 patients now on study that have developed thrombotic microangiopathy, okay, which is a severe side effect. And so that's something to keep in mind. These agents are so potent that we have no way of monitoring their potency. And so it's something that we have to be very careful with. I think it teaches us to be careful with what we're doing.
Is it dose dependent?
No, it was actually associated with the co-administration of a prothrombin complex concentrate of fiber. And so that's one thing. Thank you for bringing that. I was supposed to mention that. My cough threw me off. So yeah, so the only patients who experienced this thrombotic microangiopathy were the patients who experienced a breakthrough bleed during the study period and who received fiber as their treatment for that bleed. And so high doses of fiber were associated with the TMA. So potentially it may be this combination that is actually very bad. And so, because patients have received Novo-7 on this study and they've received hundreds of doses of Novo-7 and they haven't seen this reaction with that combination. So maybe it's the amount, because the prothrombin complex concentrates obviously have, a much more higher thrombotic potential. Maybe adding that to something that is so prothrombotic as this just throws everything off. And so, but it's very dramatic, the presentation, and you should be very careful. So unfortunately, one of my patients had this, and so, but he's doing very well. So, and it resolved with just doing nothing. And so we can get lucky, but I think it teaches us that we have to be careful. There's much to learn, and that we have to be careful. But I think for patients with inhibitors, at this point of time, this is truly life-changing for them. Truly life-changing. They get once weekly sub-Q dosing. And most of these patients have not experienced any significant bleeding episodes at all. So my patient wanted to go back on study. They were not willing, even after he experienced the TMA. Those parents were like, we want to go back on the study. It was worth it for them. So I think that tells us how much life-changing these products can be for these patients. So obviously, most of these patients have had no bleeding at all. So this was pre-study, post-study on different dose cohorts. And as you can see, the slightly higher dose. This was 6 months before enrollment, how many bleeds they had, and during the emicizumab, how many bleeds they had. And most of these patients have had absolutely no bleeds at all. So this is what I was talking about. There's two ways to do this. We know we have less of the procoagulants, so you can balance that off by adding more procoagulants. Or we can just decrease the anticoagulants so that we can balance it there too. But there is something, again, to be said for this. You have to be very careful. We don't know exactly what this balance means, or we don't know exactly how this balance could end up. If you get sick, what does that mean? Many of these proteins not only play a role in the coagulation mechanisms, but also have a very potent anti-inflammatory or pro-inflammatory pathway that they participate in. And by decreasing that or taking away some of that ability, we don't exactly know how this would change other things for these patients. So I think we have some understanding to do. So this is looking at TFPI inhibition and antithrombin 3. So if we inhibit that, we can increase the amount of thrombin. By cutting this off, we can increase the amount of thrombin that you generate. So that crosstalk is what we're trying to increase. And the feedback is what we're trying to cut off. So we said that this process is initiation amplification. This should have come first before all of this started. This is a process of coagulation, and this is the feedback that we're trying to target. So the safety of the anti-TFPI concizumab so far has also been very good. There was a dose-dependent increase in the level of D-dimers that they measured for these patients. They had good solubility, stability, long half-life. And so they have shown that in the limited population that has been studied to date, they have not found any significant or serious side effects so far. So we have to keep looking, make sure. This was the ALN83 or the sRNA for against antithrombin 3. What they're doing is suppress the production of AT3 and thereby increase thrombin generation. And with their dose cohorts, they have been able to decrease, they have said that it's safe to decrease AT3 production by 80%. I find it very hard to believe that you can cut off AT3 by 80% and still not be prothrombotic. But that's the level to which they found that this was safe in their mouse models and in some in the small patient trials that they've done. So here you go. So they lowered it by more than 75% in 9 patients, and they watched them for 300 days. That's almost a year, and they only had 3 bleeds in these patients compared to less than 25% lowering where they had a significant number of bleeds. So even though it sounds scary, I mean, it looks really good here. I still have a hard time. I would like to see more before I feel comfortable enough to put my patients on these studies. But I guess if you're looking at a patient who's really had a very bad bleeding, clinical course, for that patient, this, as long as they understand the risk that they're taking, this may be something that would be something they would be willing to try. Gene therapy, like I said, I think will be coming soon. I know we just talked about it earlier today, and we said they've been talking about this for 25 years. Is it going to happen? Maybe I think it's going to happen now. In the factor 9, definitely I think it's going to happen now. And I think the recent studies on the factor 8 have been very, very promising. They have been able to get as much as 25-60% factor 8 expression in some of these patients in some of these studies. The AAV vectors have been really optimized to be able to generate enough gene. I think the biggest problems we're having is to monitor this or suppress the immune response to these viral capsids. And also the fact that many of these patients already have inhibitory antibodies to the viral capsid, which means they can't even get this gene therapy anymore. So if we can find a way to overcome these hurdles, I think there is potentially very soon this can happen. Now, trying to tolerize a patient, I don't think I can say as much. We have very little information. We've been doing this for a long time. We've had only limited success, or most of our patients do okay, but the ones that don't succeed just don't succeed. So for these patients, we still have a long way to go. So there are 2 trials that are looking at this. One is to use an FC modified recombinant factor 8 to see if we can inhibit the production of an inhibitor at all. So children with severe hemophilia A, it's a phase 2 single-arm prophylaxis trial to see if putting patients on prophylaxis with a longer-acting product will keep the factor 8 in circulation for prolonged periods of time and prevent the immune system from making these antibodies. The other one is the higher, which is the hemophilia inhibitor response to eloctate. I think they're both out of CHOP. Am I right? Yes, they're both out of CHOP. And so they're both looking, and this one is a prospective observational study looking at inducing tolerance using the FC product. So if we can do this, the way we do ITI right now is to give daily infusions of high dose recombinant factor or plasma-derived factor, whatever it is that you want to do for these patients. They get it every single day, or at least 3 or 4 times a week for these patients. So because these factors last longer in your system, would we be able to infuse less but still induce tolerance like we normally do, is the question that these studies are asking. Again, cannot stress enough, please put everybody on My Life, Our Future. Okay, so what is the real impact of these EHLs or the extended half-life or the new products? I think one is we want to decrease the bleeding frequency, the type of bleeds that they experience, make sure that they don't have as many bad bleeds, help people stay on prophylaxis. If we can only infuse once a week, I think more people would be willing to go on prophylaxis and stay on prophylaxis. Prevent chronic joint disease. That is still a major problem in many of our patients. And if we can keep them on prophylaxis, maybe we'll be able to prevent that from happening. And hopefully these agents will somehow change the way the immunogenicity works too. If you have an FC region attached to it, does that somehow increase your Tregs? Does that promote immunomodulation in such a way that you make less inhibitors? Is that a possibility? These are things that these drugs have now given us the opportunity to potentially study. So I think that we still have a long way to go. What are these non-neutralizing antibodies? Every study finds them. Do they do anything? Do they mean you're going to make real inhibitory antibodies? What is the safety in the long run? How does that affect your immune system? Can we induce tolerance? So lots of things. The difficulty, I think, in studies in hemophilia is because we are doing so well. It's hard to convince a patient to go on a study when they're doing fine on the current factor product that they're on. So it's extremely hard. Being a rare disease, we have a limited population to draw from. And if these limited people are doing well, how can we encourage people to go on studies? It's really hard to ask people to go on studies all the time. We only have so many patients, but we still have so much to learn from them. So I think there are many questions still that we have to answer. Not all bleeding damage is evident. There are patients who bleed and don't get joint damage. There are patients who minimally bleed and get lots of joint damage. So many things that we need to understand. So I think what we're trying to do nowadays is personalized. All medicine is personalized nowadays. You're going to eventually have a chip that tells you this is what you do and you will never get sick again, I think. So we're trying to personalize in hemophilia too. We're trying to make you be able to play the sports that you want to do. We want you to be able to live the life you want to live. We want children to be able to get less factor, less pokes as much as possible. We want people to be able to stay on prophy and prevent the joint disease that we want to. Okay, we want to minimize all the inconveniences and maximize all the conveniences as much as possible. So I can't stress enough about PK profiles. I think it's really important in this new era of new medications for us to know how our patients are metabolizing their factor to be able to more effectively take care of them. So please complete your post-test so that I can see how good I did on my presentation. Thank you.
We have time for maybe just one or two questions.
Sure.
I wanted to know, you have short and long acting half-life. Have you thought, has there been any discussion about combining them so that you're about to play sports? Okay, we should do before. I'm a med student, so I don't know all the stuff.
It's a very good question. Really good question. And I think that's one of the things that we don't really know about how to make use of these extended half-life products. Because it's awesome when somebody can infuse 3 days a week and go and play. Because I know for sure your level is going to be at 90% on the day that you go out and play. Okay? But when I give you an extended half-life products, I know it's there. It's about 40% or so on Wednesday if you treat it on Monday. So which is probably pretty good. And the thing is that, that initial drop is significant and then it has a long tail before it gets off to the less than 1%. So this is the part that I have the most problem with in patients who play sports. So is that the region where I should target what you just said? Should I give you an extra regular half-life factor concentrate during that period of time? My problem with that is patients have a hard time figuring out one factor that I give them to keep at home, how much to dose, when to dose, how to dose. If I give them two different ones and say, this is how much you take of this, and this is how much you take of this, and you take this when this happens, and take that when that happens, I just worry that some of these patients may not be able to do that. That's one, okay? Secondly, the cost of care significantly increases when you do that, right? I'm using an extended half-life product, which is already twice the cost of the regular half-life. And on top of that, I'm giving you a regular half-life product. So it's something that we have to balance, and that's why I said PKs are so important at this point of time for us. It's a very good question. I don't know that I have a very good answer for you, though.
Thank you very much, Dr. Children.
Thank you for having me.
You can leave your post-test and emails on the back table on your way out. We appreciate it. Thank you.
I didn't know where to go.